the university calendar it works, but apparently with the library calendar it doesn't. So gotta work that out. But any questions about that? Is everyone okay cutting out information? I'm sure you are. But it is really redundant. One of the lectures is only like 12 slides, and the other one I think was 20. So, and it all talked about, it just expanded on communication. So that was it. Focus. All right. So we'll do this lecture, then we'll take a short break. Then we have an in-class activity that talks, reflects on clinical, and then we will talk about anger and aggression. Okay. So you talked about the nursing process all through 205 and med-surg. Why do you think it's important in psychiatric, the specialty of psychiatric and mental health nursing? Yeah, you're constantly evaluating and making changes with your patient. And then even more so with your patients in the psychiatric and mental health field, there's going to be impairment, and there's also going to be a lot of labile issues with mood. And so you're going to have to be adapting the changes that are constantly going on with your patient and adjusting interventions. And we talked about developing those therapeutic interventions when we were talking about communication. And so we know that this is a very systematic framework, and we have to use our scope of practice as a nurse and our critical thinking skills to have a very unique problem-solving approach. So everything needs to be goal-directed. And so can it be very broad, and can we utilize just the same interventions that, over and over again, or what types of interventions do we want to use towards the patient?
Ones that would promote growth for them?
Promote growth, which we talked about in the past, and they have to be very specified and specific interventions towards our patient, so patient-centered. And the goal is to deliver quality patient care that, again, is tailored to meet their individual needs. And so here, we want to make sure that we're including, and this is what's difficult with psychiatric mental health nursing, that we're trying our best to include the patient, and with that interaction, that's called building a what with the patient? You want to build a rapport with the patient, and that's rooted in developing what with the patient? A strong sense of trust, right? So relate that back to the lectures that we've already talked about. So you see how these themes that we've already talked about carry through. And so when we're talking about developing our diagnosis, that's where we're getting data. So what two types of data do we have? Our subjective and objective data. And if you relate that back to our phases of relationship development, that would be in the pre-interaction stage and our introductory phase. So those are two stages where we've got our assessment, and one stage that's unique where the patient is what? Not present, correct. So when we're looking at our outcomes identification, we know that as nurses, using our critical thinking skills, that we can expect certain outcomes. However, we want all of our outcomes to be what? Measurable, very good. We want them to be measurable. We want them to have a high probability of success and attainment. And we want them to be able to be attained in a reasonable time frame. And that's especially important now because what's happening with lengths of stay in the hospital? They're getting shorter and shorter. And so we have to be very prudent as nurses to be aware of what types of goals and outcomes we're setting for our patient, because a month now is considered a long hospital stay. And with psychiatric and mental health issues, that's pretty significant because what it does, these issues have been developing their entire lives. Because of trauma histories and things like that, we have to take into consideration that we're dealing with the brain, and we're trying to undo all of these things that are, pretty detrimental. And so that's a relatively short amount of time to fix these major issues. So we know about the care plan and planning stage, and you're going to have to do this for your case study. Then it's individualized, which you guys have already mentioned. The difference between the care plans you've done in the past and the ones that you're going to be doing now and taking a look at is that it's individualized to the mental health needs of the patient. But what are you also taking into consideration? That's why mental health is such a unique area, is you're looking at the mental health needs of the patient, but you also have to consider the what? The medical comorbidities that the patient has. So is anybody here at Norton's? Okay. So at Norton's or in any of your other facilities, if you have someone that comes in, you don't want to get sick at a psychiatric facility. We all know this, because you won't die, number one, unless something serious happens. But medical issues take precedence over your psychiatric issues, so you have to stabilize the patient first before you treat their medical, you have to stabilize the patient first before you treat their mental health needs, excuse me. I'm being very cautious about clinical groups because I felt so bad in the last section that was this morning. We did our class activity, and one of the kids, not kids, I'm sorry, but one of the students were like, told me about their experience. I was like, oh, that's great. What group are you in Wednesday with Bethany? And she was like, you had me down there all day in the annex. I'm in your group. And I was like, oh, good show. You did excellent. 2 points, extra credit. Like, I forgot she was in my own group. Like, I was like, I thought some of you guys looked familiar. There's a lot of you guys. I'm trying to remember everybody. I just forgot. So with implementation, you want to make sure your interventions are able to be executed in the time that you specified. And so with all of these specific interventions, you want to make sure that they're carried out in what type of environment? What do we always talk about in mental health nursing?
Safe.
A safe environment, excellent. We're always trying to promote a safe environment. And with this last one, or next to last one, this prescriptive authority and treatment, we're always making sure that we're in accordance with state and federal laws and regulations. So which lecture would this tie to? And what's this making sure of? Yeah, it relates back to our ethical perspectives. And it's making sure we're not at risk for any type of what? Yeah, malpractice, negligence, liability. So understanding our scope of practice keeps us free from all of that. There's pharmacological, biological, and integrative therapies and coordination of care. It's promoting that interdisciplinary collaboration, which we know that we need because what did we learn about in our psychopharmacology lecture? Are medications alone the answer? No. You need more, you need multiple therapies to be able to treat your patient. So when you're reviewing for the exam and you're studying, this is a good way to be able to start connecting information together and review for at least the way that I have a tendency to create the exams and tests. If I can go back and connect things together when I'm making up a question, then it's important on the test. So if you can do that and be like, oh, there's a theme, then you might want to mark it. That's probably important. And like if I'm doing it for you in class, then it's probably really important. Because it probably means I've already done it. So with your specific interventions, with this milieu therapy, therapeutic relationship and counseling, and psychotherapy, all of this has to do with what? we've talked about it before. Well, it has to do with building a relationship, a therapeutic relationship, and it has to do with enhanced therapeutic communication. And so with like our milieu therapy, we're making sure that everything's very recovery oriented. But since everything's recovery oriented, we're promoting that safe environment. And by using therapeutic relationship and counseling, we're either helping individuals regain lost and past coping skills, or we're helping people develop new ones. So regain lost coping skills or helping individuals develop new ones. And then with our psychotherapy, you guys just got done with research, so what do we want to make sure all of our psychotherapy techniques are rooted in?
Evidence-based practice.
Utilizing evidence-based practice techniques. So all psychotherapeutic frameworks need to be rooted in evidence-based practice. And we want to use these in combination with what? With our psychopharmacology. So we want to combine therapy and medication, using our nurse-client relationship to get the best results. So we want to use therapy and medication with our nurse-client relationship to get the best results. And with evaluation, we just want to make sure that we're obviously measuring everything to make sure that our outcomes and interventions were successful. And if they weren't, what do we do? Yeah, we change them and we reevaluate, and hopefully we'll have a successful result. So this question isn't the best, but I left this in here because it's a good way to make sure you're not getting distracted and reading too much into a question. So according to the American Nurses Association Standards of Practice for Psychiatric Mental Health Nurses, which specific intervention can be implemented by any psychiatric mental health nurse generalist? So that's basically saying you an ordinary nurse. Milieu therapy, can we do milieu therapy as nurses? Yes. So right off the bat, you're like, okay, we can do that. Psychotherapy. We do psychotherapy. See, that's why. Everybody's like, can we? No, we're not therapists. I'm not licensed therapists. I don't know, we can do groups. I have no idea. Consultation, can we consult? You're like, you can educate, can we consult? I don't know. Can we prescribe drugs? No, so that's definite no. So we know we can do milieu therapy, so we were certain on that. So A is the correct answer. Pardon me?
What is that, milieu therapy?
So it's basically milieu control. Like you're able to control the unit through the nurse-client relationship. You're able to keep control of the unit, make sure it's a nice, positive atmosphere. That you're able to keep control of the patient. Make it a dynamic environment, positive, learning, fun, not out of control. With these two, the reason I said it's a kind of a poor question is because this is one where I'd get students in my office saying, well, nurses can lead groups, medication groups, so you could be a therapist. Well, yeah, but you're reading a lot into it. You're not licensed therapists, but you can lead groups. Nurses can't educate, but you're having to rationalize the selection in your mind to make it fit, kind of put the peg in a hole type thing. So don't read too much into the selections to make it the correct selection. No, you knew A was correct right when you read it. So this just gives some background about nursing diagnoses. You're not going to be tested over any of it, but it is kind of interesting to know. Overall, this just talks about the nursing diagnosis is describing the patient's condition, prescription of interventions, and parameters. So which nursing diagnosis is written correctly? I'll let you guys take a look. I don't want to read it and confuse you. C? Yeah. C is correct. So C has all the correct parts that you're supposed to have for a nursing diagnosis. Okay, so this applies loosely to your psychiatric mental health nursing. And the reason is because when you're involved in psychiatric mental health, why do you think case management is very important?
Because don't they have like maybe other therapists, other people on the team that to collaborate and help take care of them, so someone can manage all their services?
Yeah, because there are multiple services that are combined to take care of your psychiatric mental health patient. And if your psychiatric mental health patient is the best equipped to make their own medical decisions a lot of times. No, they're not. So they have to have someone there that helps collaborate all of their care and make sure that they're making the best possible decisions that they can and negotiating with all the different providers. Because they do have a lot of diverse services, which it talks about up here, because they've got physicians, they have specialists, they have a lot of medical needs as well as psychiatric needs. They have a lot of outpatient appointments that relate to maybe substance abuse, rehabilitation, medical rehabilitation, long-acting injectable clinics. I mean, all these different types of things, and transportation, because a lot of them can't drive, they might have housing issues, social services. And so they've got all these things, and it'd be hard for us to keep it straight if we're a relatively organized person and we can write things down, and appointments and phones and alerts and all this. They can't keep track of any of that stuff. I mean, they're good to get up and shower every day and brush their teeth. Like, they can't keep track of any of that. So this is good because it decreases fragmentation of services. And also it keeps costs from spiraling out of control so they can keep within the same system or organization. It helps keep costs down so you're not going all over the place. Like maybe keeping it within Kentucky One Health, which will be hard because they're getting sold off and they're like all big room. So maybe keep it within Baptist or Northern. We were talking about that. Can you imagine a Jewish town if that's going to do Louisville? Wouldn't it be horrible? There literally won't be enough beds. I heard there won't be enough beds to accommodate clinical placements for nursing students in the city of Louisville if a Jewish shuts down. With managed care, like a lot of employers and insurance-based corporations do managed care. And that's where you group everybody together. You have tiers of service. You try and maintain quality and control costs by doing this, but it takes out a lot of what? It takes out a lot of choice and decision. We talked about this already, it's kind of repetitive. It's coordination of services to meet the needs of the patient within a system that's very fragmented. You know, we're just now, you don't think about that, you think of our, how many in here are wanting to go to graduate school? I think I've already asked, but a lot of individuals in here. You think about the United States healthcare system as being very advanced and very, look at Steve, don't smile. We've got the one exchange student here, she's grinning because she knows, she's like, this place is a hot mess. Because you guys have universal health care in Australia, don't you?
Yes, we do.
I should just go back with you. Because it would be nice if we all had health care that the government paid for that was free. But I don't know how we pay for it because, you know, we're $22 trillion of debt, so I don't know where that money's gonna come from. But if we could figure it out, it'd be great. But like Australia has universal health care. Japan has it, they've had it for a long time. And they have the highest life expectancy in the world. But whenever you look at being able to care for your patients and provide the best services for your patients, there's a lot of fragmentation within the United States healthcare system. There's a lot of what they call silos, and you'll learn about this if you go into graduate school. People just don't communicate, and so you have a lot of redundancy within the healthcare system about repeating services that aren't needed, and things getting lost, and patients' information and charts getting lost, repeat tests that cost tons of money, CAT scans and this and that. I mean, things that just skyrocket services. Insurance corporations charging numerous times for services. It's really unbelievable. And that's just because of poor communication and poor documentation. When you look at critical pathways, this is one way they try and keep costs down, but it's also one way that individuals can make a lot of money as well. And this can happen whenever you look at mental health patients that have medical comorbidities. So right here, when you talk about uncomplicated cases, when you've got some of these medical comorbidities like diabetes or coronary artery disease or heart disease with your psychiatric mental health patients, they'll fall under this critical pathways plan. And for uncomplicated cases of these types of diseases, they'll have standardized treatments that just they get lumped in with. And so certain treatments will be provided by an interdisciplinary team. And it's just standard and routine, so they don't get individualized treatment at all. It helps keep costs down, but then they charge certain amounts. So when you look at applying this nursing process and how it relates to psychiatric mental health nursing, one thing that you want to make sure that we're doing is that we're always trying to be able to manage the patient's stress, and that we're keeping the patient, we're improving the patient's coping skills, and that we're helping them have successful adaptations to the stressors we're subjecting them to in the environment and within the inpatient setting. And that the goals we're developing towards for the patient, that we're trying to change and evolve their thoughts, feelings, beliefs, and attitudes to be able to get them to cope better whenever they get discharged. But when you talk about things being age appropriate and in line with cultural norms, that goes back to the previous lecture we talked about whenever we talked about the beliefs, attitudes, and values. And whenever you talk about things being age appropriate, it really should be patient appropriate. Because just because a patient's of a certain age in the hospital, does that really mean that it's appropriate for that patient specifically? Not necessarily, because some of our adult patients in the psychiatric mental health setting, what can they be? They can be developmentally delayed, cognitively impaired. I mean, I've met 18-year-old patients, like at Our Lady of Peace, that are on the forensic unit or something. There's really nothing wrong with them mentally, but they're 18 years old now, they're out having sex and doing stuff that I've never heard of and had to look up like on the Urban Dictionary and stuff because I don't even know what they're talking about. When I hear them talking, I'm like, oh my Jesus, what's... But then they can't spell their own name. Like they don't know. I mean, they're using 4th and 5th grade level books and they're damn near in college. Like it's sad. I mean, because they have no education whatsoever. I mean, you're like, really? Like, they think the Titanic is fake. Like, they don't realize it's based off a true story. Like, when they're watching it on TV. Like, that is a real damn boat. It really sank. Like, it's not just so you can see Leo. Like, they don't understand. They have no education. It's so sad, but frustrating at the same time. So what's the nurse's contribution in all this when you look at applying the nursing process and the role in psychiatry? Well, we know that there's an interdisciplinary team that plays a huge role. But the big thing here we've talked about is the communication aspect. Well, this team's so spread out, and then we talked about that with the fragmentation of services. The nurse is the one that's on the front lines, and it's really playing the role of the connection between the patient and everybody else that's on that team. You're the one that sees them on a day-to-day basis. And like we said in the past, you're the one that develops that rapport and that trust with the patient. So something to kind of highlight in red pen. You're the one that sees those day-to-day accomplishments and reports that to the rest of the team. So you're making a huge contribution as far as being able to report on the daily behavior and the daily progress of the patient. I know you guys have used concept mapping before. We started using these the past few years in the nursing program. And this helps to show interrelationships between the medical and the nursing diagnoses. It helps to improve utilization of assessment data and the benefits of treatments. Several times throughout this course and through the lectures, we've talked about problem-solving models and critical thinking skills. So this concept mapping helps to enhance those and to adapt your own types of thinking and learning behaviors. The big thing to note is it doesn't just help students, it helps all people because we still utilize concept mapping within a clinical setting. But it helps you to develop a holistic view. So if you saw that in a multiple choice question, you'd be able to identify that it's a holistic view of their clients. Should be pretty easy to recall. So why is documentation so important? In any medical setting, but especially in the psychiatric mental health care setting, why do we want to document?
Prove you did it.
Yeah, if you didn't document it, it didn't happen. And it also protects you from what?
Negligence.
Yeah, protects you from negligence, any type of liability. And we also know that it plays a huge part in accreditation. The big thing is, you want to document it because it shows that certain things were carried out and that it helps you as the singular nurse, the individual nurse, and also the entire facility that you're working for. It helps protect them from liability. For example, Saturday when we were at clinical, I was in nursing service. This is like a house manager's nightmare. Not a big nightmare because it's not really your fault. You just document it and move on. But we got a call that Friday a patient was discharged early in the day. Went home, they did whatever. This mother's known to be a pain. I remember who she was. I recognized her from when I worked there. Little girl got discharged. Saturday, it was early afternoon, mid-afternoon. And mother called and said, went to the ER this morning. My daughter's wrist is fractured. You guys fractured it. What you gonna do? Okay, well.
He told.
So we look up the patient. There it is, the patient. I just sit there. I was like, oh, nurse documented. It was bad. We don't document very well in peace, but sure enough, no note was done. Now there was a note that the narrative note that the patient hurt themselves in the gym and complained of pain to the nurses, and one pain scale was done. Okay, well, this confirms that the patient hurt their wrist. Was there a reassessment done? Oh, no reassessment was done. So we know that the patient hurt their wrist, and so we committed that one. Wish we'd let that one out. But we didn't ever reassess them. And we didn't get an x-ray or anything. So could they have broken the wrist there? Well, we admitted that they hurt the wrist. We didn't follow up on it. Now we have a radiologist that's on call all the time. We could have ordered a nurse practitioner consult. We could have documented that we reassessed their pain and maybe their pain level was 0 after we gave them Tylenol. That would have helped ease it out a little bit. We didn't do any of that, so that puts us in a pretty sticky spot. So now risk has it, we'll investigate and do all that kind of stuff. But see what happens when you don't document something simple. Now what do we learn in nursing school? Patient says they're in pain, you assess them, and you go back how long? And in an hour, you assess them again. If it's a little kid, you know, ow, ow. Okay, well, I'm gonna call the doctor. The psychiatrist don't know what the hell he's doing, so he's gonna order he's like, I don't do wrists. I do this. So, call the nurse practitioner. So, he'd call the nurse practitioner, they'd come. Nurse practitioner was like, I can't see through bones, so I'm gonna call the radiologist. They came in. See how this all would have fixed itself? Simple stuff, simple stuff. So, those are just little things that you don't think is a big deal. And then do you want to be that nurse that didn't reassess the patient in an hour and they get all these orders? No, you don't want risk calling you. That's how risk calls you right there. And that's where you feel real stupid. Whenever you're trying to chill on a Saturday and then you get that call. Look at that. You're like, I'm about to go drinking. And then you get risk calling you on Saturday. That sucks. That's when your Saturday's ruined. Ruined. Yeah. You don't want those calls. That's when you're like, my job just ruined my life. So, you gotta wait till Monday to figure out what the answer is. They're like, yeah, come and just don't bring anything else. Make sure your badge and your keys are with you though, we just got chit chat. And you're like, correct. So problem-oriented reporting. So, I'll tell you if I'm gonna, I'll give you a hint, won't tell you, but I'll strongly hint if I'm gonna ask you to define and like list out any of these little acronyms, but there's so much other information I doubt that I will. But follow the SOAP format. So we used to use SBAR, Situation Background Assessment Recommendation, to actually document our charting, as well as doing verbal communication. But they use other stuff as well for documenting the nursing process. This SOAP, which is subjective, objective assessment plan, implementation, and evaluation. They use the DAR, which is shorter, it replaced that. Everything has to be, which is data, action, and response. If you notice, everything's nursing related. It can't be focused on a medical diagnosis, which you've been taught that since 205. And this PI method, which is specifically API, it's very problem-oriented. And we know that flow sheets accompany a lot of documentation. And they're important in the psychiatric mental health field because they show basically every 7.5, 15, or 30 minutes exactly what the patient's doing and monitors their behavior. Were they being aggressive? Did they punch somebody? Did they eat a crayon? What were they doing? And so it documents by assessment, problem, intervention, and evaluation. So which type of documentation is subjective to this up here? If I give you a question like this, just say maybe 2 points. D. I'm sorry, but I doubt there will be any that are just like that straightforward. Okay, so why are EHRs important? Electronic health records. Why are they good for just nursing in general, but especially psychiatric mental health nursing? What's the benefit of the electronic health record?
It's like information in real time almost.
Yeah, very good.
Everyone to look at.
It's real-time information. So highlight in red pen this slide, mark it down as something that would be a good possible short answer question. And here's the reason why. So there's these 8 core functions of the electronic health record. And there's rationale that's tied to each of these 8 core functions. So with your health information and data, the reason this is important, the rationale behind it, is because it allows for rapid access to patient information. And it allows for there to be sound clinical decisions. So sound clinical decisions can be made in a timely manner. So rapid access to important patient information and sound clinical decisions in a timely manner. With your results management, computerized results can be accessed so much more easier. applied to patient issues. With order entry and order management, computer-based order entries can improve workflow, and it eliminates confusion. There's no lost orders or illegible handwriting on the part of physicians. With decision support, the EHR provides prompts and reminders. And with electronic communication and connectivity, we talked about interdisciplinary importance, and the EHR does this automatically with all different areas of the hospital, all different departments. It communicates automatically with all of them. With patient support, it's very interactive for the patient, and you can provide information relatively easy through printouts. With the administrative process, it eliminates paper. It allows for increased efficiency, self-scheduling, and decreased redundancy. And then for reporting, it automatically reports data to monitoring agencies. So for this, the setup of this for a short answer is, I doubt that I would ask you all of these to fill in, but I might ask you a selection of them. I might list all of them and then have you give give the rationales. I wouldn't just be like, a core function of EHR is gonna be like, have at it, because that would be a lot. But I might list these right here, and then have you put the rationales down. Or if you guys have had like matching, I know like Julia and have you guys had matching type things, or, no, okay. No, Julia hasn't done matching, that's a little tough. But, I'll probably have you fill things in. Okay,